For some, alcohol is a way to relax or connect socially. But for many, it slowly turns into a silent threat, damaging not just lives and relationships, but the liver itself. Alcohol-associated liver disease, or ALD, has become a major global health concern. It's now one of the leading causes of liver failure and death across the world. What makes it even more tragic is that it's largely preventable and often treatable if caught early. This talk takes you through the journey of ALD, from how alcohol harms liver cells to how we can act early and care better. Backed by the latest global research and recent guidelines, we'll focus on both the science and the human side of this condition. Whether you're a doctor, a caregiver, or someone looking to understand the risks, this is about knowledge, action, and hope. The global toll of alcohol-associated liver disease, or ALD, is immense. Alcohol causes nearly 3 million deaths annually, with ALD now the leading liver-related killer worldwide. Worryingly, the burden is shifting. Young adults, women, and populations in low- and middle-income countries are increasingly affected, turning ALD into a fast-growing global health crisis. ALD isn't a single diagnosis, it's a clinical continuum. It begins silently with steatosis, or fatty liver, which is reversible. But with continued alcohol exposure, the liver inflames. This is alcoholic hepatitis, which may evolve into fibrosis, then cirrhosis, and ultimately, liver cancer in some. The good news? Intervention at any stage can halt or reverse the damage. The tragedy? Most patients don't realize they're at risk until it's too late. Alcohol may be socially accepted, but its path through the body tells a darker story. When consumed regularly, it quietly turns into a slow poison, breaking down the liver piece by piece. After ingestion, alcohol or ethanol is quickly absorbed in the upper gut and carried to the liver via the portal vein. That's where the real trouble begins. Inside liver cells, ethanol is mainly broken down by the enzyme ADH1 into acetaldehyde, a toxic compound. In chronic drinkers, another enzyme, CYP2E1, becomes active, producing even more acetaldehyde along with harmful reactive oxygen species, or ROS, that damage liver cells. Acetaldehyde is highly toxic. It disrupts mitochondria, damages DNA, alters proteins, and causes fat oxidation, setting the stage for progressive liver injury. Normally, acetaldehyde is converted into a less harmful substance, acetate, by the enzyme ALDH, but many people, especially of Asian descent, have an ALDH2 deficiency. This causes a buildup of acetaldehyde, leading to facial flushing, nausea, and discomfort, even with small amounts of alcohol. The acetate is further converted to acetyl-CoA, which fuels fat production in the liver. Over time, this promotes buildup of fatty acids and triglycerides, leading to fatty liver. Chronic alcohol use disrupts the liver's chemistry. It increases the NADH-NAD+ ratio, blocking fat breakdown. At the same time, it rewires gene expression, pushing the liver to make more fat and stop breaking it down. Alcohol's impact isn't limited to the liver. It also drives fat release from body stores and boosts fat absorption from the gut, overwhelming the liver with more fat than it can process. The result? Fat begins to pile up inside liver cells, causing hepatic steatosis, commonly known as fatty liver. If drinking continues, this silent damage snowballs, from inflammation to scarring, then cirrhosis, and eventually liver cancer. Not everyone who drinks heavily develops ALD. So, what determines progression? Women are more susceptible due to reduced alcohol metabolism. Binge drinking, obesity, and coexisting liver infections, like hepatitis B or C, greatly increase risk. Genetic mutations like PNPLA3 can tip the scale toward fibrosis. And smoking? It's not just bad for the lungs, it worsens liver inflammation too. Diagnosing ALD demands a careful and thorough approach. Start with the story. How much, how often, and how long has alcohol been consumed? Validated tools like AUDIT-C help quantify the risk. Biochemical markers can show early cell injury, and elastography allows us to assess fibrosis without a needle. But in select cases, a liver biopsy still provides definitive insight. ALD cannot be treated in isolation from alcohol use disorder. Addressing the liver without addressing the alcohol is like fixing a leak without turning off the tap. Therapy works. Medications like baclofen are safe even in cirrhosis. Recovery takes a team, a therapist, a physician, a support system, and most importantly, a willing patient. Alcoholic hepatitis, or AH, is the most feared phase of ALD. Unlike the silent steatosis or slowly progressing fibrosis, AH crashes into patients with sudden, life-threatening liver inflammation. Jaundice, fever, and confusion may mark the onset. A MELD score above 20 signals danger, and the LEAL score helps determine who might respond to steroids. The urgency is real. Up to half of patients with severe AH may not survive beyond 90 days. In alcohol-associated cirrhosis and hepatitis, patients often struggle with deep tiredness, malnutrition, and visible body changes like abdominal swelling, jaundice, and fragile skin. The eyes turn icteric, hands may contract painfully, and facial changes like rhinophyma can appear. Hormonal imbalances lead to gynecomastia and loss of libido. Neurologically, they may suffer from nerve damage, tremors, seizures, or slip into confusion and coma due to hepatic encephalopathy. Some face the devastating memory loss of Wernicke-Korsakoff syndrome. These signs reflect the profound toll alcohol takes on the body. For severe alcoholic hepatitis, prednisolone remains the cornerstone therapy, but only for those without active infections or GI bleeding. In some cases, adding NAC can reduce oxidative damage and improve early survival. Emerging options like G-CSF designed to regenerate liver cells offer hope, but they remain investigational. And some former therapies like TNF inhibitors have shown increased risks without benefit. As always, caution and evidence must guide our choices. 2024 brought several breakthroughs that could redefine how we approach ALD. From novel biomarkers like CK18 and SCD-163 that allow for earlier and more precise diagnosis, to fecal microbiota transplantation, which restores gut-liver balance and shows survival benefit in severe cases. Innovative therapies like IL-1 blockers and mesenchymal stem cells are being tested to calm inflammation and rebuild damaged liver tissue. And for cirrhosis-related portal hypertension, carvedilol is showing superiority over traditional beta blockers. These aren't just new treatments, they're new frontiers. In ALD, the liver is starved, but so is the rest of the body. Malnutrition is present in the vast majority of cases, and it directly correlates with poor outcomes. Daily protein and caloric needs must be aggressively met. Vitamin and mineral deficiencies, especially thiamine, must be corrected. Nutrition is not an afterthought. In alcoholic hepatitis, it's a predictor of survival. Liver transplantation remains the only definitive cure for end-stage ALD and steroid-refractory AH. Historically, a 6-month abstinence rule blocked many eligible patients, but today, early transplantation, even without prolonged sobriety, is accepted in well-selected individuals. It's not just about liver function anymore. We must assess commitment, psychological resilience, and social support. When done right, post-transplant outcomes are equivalent and relapse rates are low. Recovery from ALD doesn't stop after discharge or transplant. It's a lifelong commitment. Patients with cirrhosis need routine HCC surveillance, and their immunizations must be up to date. Managing diabetes, weight, and smoking is essential. But perhaps the most critical factor in long-term success is continued alcohol abstinence supported by counseling, medication, and community. Alcohol-associated liver disease is a paradox. It's one of the most devastating chronic diseases we face, yet it's one of the most preventable. Early diagnosis, sustained abstinence, compassionate, evidence-driven care. These are our tools. With every patient we educate, every life we intervene in, we rewrite the story. from one of decline to one of resilience. And thanks to modern science, that story has more hope than ever before. If you found this video helpful, please like, share, and subscribe. This may be medical content, but at its heart, it's about people. The fight against ALD doesn't start in the ICU. It starts with awareness, empathy, and education. Thank you for being part of that mission.